Good afternoon, everyone. Thank you for joining us. We'll just wait half a minute or so to allow everyone to join. Everyone will be placed on mute as they join. We'll give it a few more moments, let colleagues join the call. We'll be using the Q&A function for questions, so please do put your questions in there, but there will be some lots of time at the end for questions. The webinar will be recorded and will be made available to everyone that has signed up today. Okay, I'm going to hand you over to our chair for today, Graham Wilkes.
Thank you, Ali. Good afternoon and welcome to everyone to this Connect Health Change series webinar, which the intention of the series of webinars is to create discussion around transformation in healthcare. We've had a number of topics covered previously in our webinar series, including artificial intelligence, first contact practitioners, chronic pain and COVID-19 rehab. And if you would like any links to any of those seminars, we can supply those if you want to look back over on them. So today we're going to focus on mental health. That's why you're all here, because you've got an interest, and particularly around improving access to psychological therapies. So we've got 5 really good speakers lined up with a broad range of experience in mental health and IAPT in particular. So each speaker is going to speak for 7 minutes, and then we're going to take a couple of questions after they've spoken. And then if you could indicate any questions in the question and answer box, at the end we'll have a final session where we'll pose those questions to each of the speakers. So the speakers are, I think you'll find, impressive in terms of their experience, and you can find their biographies on the website. I'm not going to refer to that directly within the webinar. So just in terms of why are we all here? We're here because mental health is a problem in the country. It has been for some time. IAPT services was set up in 2007 and have addressed gaps within the market for service provision. But the challenge now is to take that on to the next step. You'll all be aware of the mental health forward view and the long-term NHS plan, where mental health has been nominated as a priority, both in terms of funding, so £2.3 billion, but also in terms of transformation of the service. And I think you'll be aware some of the key targets are to increase the access to a large number of patients with a target of 2 million. And also to reach into long-term conditions and match up finally physical and mental health, which is tended to run in silos. So these are all challenges for us over the next 5 years, and we're going to address those in the webinar today. Just before we go to the first speaker, I'd just like to introduce you to our board assurance prompt. So you should see the slide there. The board assurance prompt is a piece of work that was done by the Good Governance Institute, who are a group of very experienced healthcare leaders that try to promote quality in healthcare. And the board assurance prompt gives a briefing on IAPT services in England. So this was put together by a group of experts that the Good Governance Institute brought together in conjunction with Connect Health. And it sets a number of key assurance questions that can be posed to providers or commissioners when designing or procuring IAPT services. The maturity matrix supports those organisations to try and understand what the challenges are and whether the services that they're involved in or planning come up to the appropriate standards and requirements. So I'd encourage you to visit the website to have a look at that. You can see the document in full. and certainly I would suggest you have a look at that, because I think it is an important document with some key leaders who've contributed to that. So we'll go on with the webinar first. We've got 5 speakers for you. I'm pleased to say we've got, as well as clinicians, we've got a very strong patient voice in the first and the last presentation, which I think is very welcome. So we'll go to the first speaker, who's Charlotte Oust. Charlotte's Chief Executive of National Voices, and she's going to give us feedback from a patient survey that she's been involved in, which is very relevant to mental health. So I'll hand over now to Charlotte to start us off with our first talk. Thank you, Charlotte.
Thank you, Graham. Thank you for having me. Could you start my slides, whoever's doing that? Thank you. So yes, Graham's already said I'm Chief Executive of National Voices. National Voices is an umbrella organisation, so we are basically a coalition of charities. All the large household names you've heard of, you know, the British Heart Foundation and Macmillan and Alzheimer's and diabetes and so on and so on. But obviously also hundreds of those that you might not have heard of unless you have a family member maybe with a rarer condition. We also have some members who are more sort of cohort specific, so supporting older people or supporting gypsies and travellers, or, you know, sort of different cohorts of people. We want to humanise and democratise health and care. We think we need to just shape health and care in a way that it actually supports people. And we do work across the whole health system. We engage with all senior system partners and try to bring the insight from our members that they derive from working very directly with people and communities to decision makers, to ensure that the lived experience of people is at the centre of decision making. If we go to the next slide, that summarises the stuff we've got up to during the first wave of the pandemic. So basically, we felt it was quite urgent to document and understand the experiences of people who live with quite substantial health and care needs. These are largely people who live with chronic ill health, disability or impairment, and those are the sort of people we support and represent. And we did a number of outputs. And I'm mostly going to talk today about what we need now, which is a very substantial qualitative piece of work we've done. But I just want to flag up the other pieces of work, and when the slides are shared at a later stage, you can also click through to the website where you can find all the information. So Dr. will zoom you now is a qualitative study into people's early experiences of health and care moving online. We worked with Traverse, who are a research organisation, and with Healthwatch England. They engaged online with people about their online experiences. And because obviously that excludes people who aren't online, we did some telephone interviews to complement the methodology. So we spoke to 22 people who were not online about their experiences of care having been moved online and onto remote models. So if that's a question you're interested in, please have a look at that. What we know now is a quantitative piece of work that basically is a meta-analysis of, I think, 12 surveys our members have done. So many of our members, charities, surveyed the people they support. And 12 of those were shared with us. And we read across all of those what they all tell us, and this is the equivalent of 66,000 responses. So this is a very large number of people with substantial health and care needs who told us what happened during the first wave. And quite relevant to what we're talking about today, people say very clearly that their mental and physical health has been quite adversely affected during the first wave of the pandemic for various reasons: loneliness, practical difficulties, financial worries, but also the withdrawal of their usual treatments and their usual support packages. Patient noun adjective is a piece of work that looks at that last problematic in detail, the last one I mentioned, which is about how do people cope when their treatments are disrupted or delayed? And we try to understand what would help people in that situation. It's obviously not desirable that treatments continue to be delayed and disrupted, but we feel some of this is now unavoidable, and we've seen this in areas where they've had to deal with high COVID infection rates, that elective care and ongoing chronic conditions care was disrupted once again in this second wave. And now I'm going to talk about what we need now, which is this qualitative piece of work that we started early on during the pandemic in early May. We created a platform we called Our COVID Voices, where people with substantial health and care needs could talk about their experiences during this first wave. And we gave them a very loose brief. We said you can write up to 700 words. You mustn't swear and you mustn't identify anyone who doesn't want to be identified. And once or twice people talked about stuff that we needed to go back to them about because we had some safeguarding concerns. But other than that, we just published what people said. And for people who couldn't go online and write their stories, we also offered that we would interview them. And so the platform also provides summaries of interviews we did with learning disabled people and people who live with dementia in particular. And we then also, as well as analysing the first 50 stories people told us on this platform, convened a number of those people, I think it was 35 of them, into 2 focus groups. The first focus group looked at the topics we thought we had heard and just checked that people had agreed that we'd captured their insights sufficiently. And the second one, we tried to turn their experiences into a set of expectations as to what they now say they need during the second wave and going forward into a ongoing pandemic response, or maybe even a post-pandemic situation. And we called this piece of work What We Need Now. And it sort of culminated in the creation of 8 statements that basically summarize what these people told us they need now from health and care services. And if you go to the next slide, please, I can talk about the first 4 of these, and then I will talk briefly about the next 4, and then I hand you over to Graham again. So we turned these expectations into I statements. So that's someone in a first person account saying, this is what I need. The first one is the one that people decided was the most important one, because we also asked them to vote on the relevance of these various statements. And it was also the one that people found the hardest to get right. So it took the most iteration, this particular statement, because what people said very clearly was that they don't just want to be able to say their stuff. They want someone to actually listen and act on what they say. So there's something here about a sense of control and autonomy, I think, that merits, unpacking. We've got one about rights. And again, something about protecting a decision-making space for people where they can rightfully make decisions. Then there are some unsurprising ones. Given the situation we're in now, people felt that the information they had been given during the first wave of the pandemic, remember these are people with substantial health and care needs, was very deficient, confusing, contradictory, late. Even the shielding information was described as totally insufficient. There's a sort of subset of problematics around information about risk, which is captured by the 4th statement. And people here expressed to us a very clear expectation that those people who'd been written to by the government and told sort of on government-headed letter paper that they are at extremely high risk if they catch COVID, that they also now wanted to have a conversation with someone who could help them understand that risk and how they could mitigate it. And that's both the risk that is inherent to them having a certain condition, but also the risks of everyday activities. People wanted to understand the risks involved in, for example, their particular professional occupation. They wanted to understand the risks involved in commuting or in shopping or in meeting family. And we tested who they felt they needed to have that conversation with. And for those who have very significant health and care needs, they felt that this needed to be a specialist. So if you are a double lung transplant patient, they felt they needed to have a conversation with their lung doctor and their transplant doctor. Others felt it could be a GP, but certainly someone who knows them. If we go on to the next page, it shows the last set of I statements. The 5th one is really sort of a hardy perennial of patient advocacy, in that people always say they feel they haven't got a good understanding of who's in charge and how to get hold of them. So this has never gone away as an issue, but what we heard very clearly was that it's got much worse because pathways are so disrupted and people have just been sent a letter saying you would normally have had this operation or you would have normally had this checkup or this procedure. It's now off. They really did not have a clue as to whether they were still under the care of a specialist team, whether they had been handed back to the GP, whether the person they'd been handed back over to was aware of that, how to get hold of that person. So there was even more of a need to clarify how, whose problem are they? The sixth one, again, is very COVID specific, and it's about assuring people that they're safe. And what we heard very clearly there is that people don't just need a glib statement that says we will do everything to keep you safe. People really want you to walk them through what you're doing to keep them safe. So you will wait in the car park until you get called in. Your member staff will wear a mask. We will give a mask to you. We will ask you to use sanitizer. The room that you're going into will have been cleaned 20 minutes before you've gone in, and so on. Really detailed information. And what I took away from that was not that people are going to retain all this information, but that they wanted to feel that you had in practical terms addressed their concern, not just, yeah, we care about your safety, but actually practically addressed what you could do. I think there's real food for thought there about how we communicate these arrangements to people. The seventh one is about the experience of waiting, and that's why we did the work on patient noun adjective that I talked about earlier, because we heard so clearly that people felt utterly abandoned when their care was just cancelled, and they really felt like they were no one's responsibility, and they didn't know when they would hear from services again and what they could do in the meantime, or who else they could turn to. And then the final one is the one that people decided was the second most important statement. And there was a very strong sense, and we were now talking in the summer when we had these focus group conversations, that in the move to loosening the first lockdown, people who are more vulnerable to the virus and who need health and care to work better than it currently does, have been forgotten. So by way of takeaway, really, for today's essay question, which you are here to hear about, I think, as always, when you talk to people, they don't distinguish between mental and physical health in the way that the health system does, and certainly our participants didn't. And they talk about physical and mental well-being in one breath. It is the same thing from their perspective. And the things that often the system lets them down on, pain, fatigue, breathlessness, anxiety, are exactly at the interface between physical and mental health. And that's, I think, partly why our siloed way of thinking about those two areas isn't really supporting people who've got quite substantial needs. So what people said to us, I think, what these statements summarize, is that health and care now needs to urgently discuss with people what helps them cope. That is the essay question for the next 12 months or so, because they might well not get their hip replacement, they might well not get their endometriosis looked into, they might well not get their cataract operated on, but what helps them cope now? And that is exactly at the interface of mental and physical support. And I would add to that also practical support. And that's obviously also where the VCSE and the charities that we work in with have an important contribution to make. I leave you with that thought, and I'm interested to hear your thoughts and your questions. Thank you.
Thank you, Charlotte. That was very instructive, and to hear the patient voice and the number of patients that you accessed. And certainly I would encourage people to go online to National Voices and download the November document that that Charlotte has talked about. So just one question, and then there'll no doubt be questions at the end. So you talked about there at the end what helps people cope. I guess for all of us working in healthcare, physical and mental health, it's a new world. Next year is coming, and there's some great information there. I mean, is there one key thing that you could suggest that came out of all the discussions you had, one fundamental error that we are making that patients continually feedback about?
I think if I had to zoom right out and say just do this one thing, I would say be honest with your patient about what's possible and what's not possible by way of healthcare right now, and then open up a conversation about what the patient themselves thinks would be helpful in the meantime, whilst we wait for whatever it is that can't happen right now, be that face-to-face support, be that a medical procedure, and so on. And I think in that, acknowledge the hardship. And I think there's something about trauma-informed approaches, and I don't want to go too, carried away with that, but I think just even acknowledging that lockdown has been really hard for people, and that people who normally would use health and care services very regularly and were very much cut off from all this support, some of those people have experienced really terrible situations. Even just acknowledging that, I think, will take the pressure off. And we need to do everything we can, I think, to take the pressure off people's mental health.
Yeah, and just one quick question, then we'll move on to Marie. Can some of the I statements, this has come from what one of our attendees, can some of the I statements be helped by improving people's internal resilience? And if so, how can we do this on a population basis? So how can we move that individual intervention to a population?
I think that's a question of sort of leadership almost as well, isn't it? It's like the clinician sits with one patient at a time and can only talk to one patient at a time. But system leaders talk to a lot of people. So that's system leaders in the health system. If you run the outpatient departments of so-and-so, if you run the physiotherapy department or the psychological therapist department of so-and-so trust, you talk to a lot of people. So I think that's an opportunity to say some of these things that help people cope, like acknowledging trauma and making it clear who's in charge and making it clear how you can get hold of this person, making it clear when you will reach out again, and those sorts of bits of information. I also think there is a level above that, which is the sort of political and social leadership we have. And I think the thing that I regret the most really about how we got through the first wave and how we arrived at where we are now is that I feel we've had a real absence of that very clear values-based leadership that would have helped us to stay united in facing this massive challenge, and that we have allowed this initial moment of unity that happened early on in the first lockdown in a way to disintegrate and to start a very tribal response to what's going on. It's the old people who are dying, not the young people. Why do we care about them? It's the young people who are causing it. We need to stop them. It's the Asians who live in large households, they're to blame. I think it's become really very fragmented, and that, I think, will decrease our resilience in dealing with the challenges that next year will still very much hold. And I have a real longing for a different kind of leadership that speaks to all of us in a different way and taps into our goodwill for each other.
Thank you very much. That was brilliant. You've obviously got a lot of knowledge there, which I think is invaluable. And I'm sure these points will come up in later questions again. So I'll move rapidly on. Thank you, Charlotte, to the next speaker, who's Marie Challingsworth. Delighted to have Marie speak to us. She's a very, very experienced in mental health and IAPT services. She's Group Clinical Director for the Concern Group, who provide a number of IAPT services around the country. So she's going to hopefully help us understand or give some wisdom on how we get from where we are and where we're going to. So over to you, Marie.
Thank you. So yes, welcome everybody. So if Graham goes to the first slide, I was just going to kind of briefly give you an update on kind of the IAPT programme and where we're going in terms of long-term conditions, and also kind of the journey towards IAPT for a little bit of context, really, in terms of before the IAPT programme came live in 2008 and before the kind of pilots and Pathfinder sites before that. The situation was that often people would wait to see a therapist like me for up to 24 months for an assessment, and then potentially another 12 or 24 months for treatment. So obviously that meant that we couldn't meet NICE guideline care, which, you know, if you think about parity between physical health and mental health, if somebody needed any kind of physical health operation or surgery, or that would never have been an acceptable situation. So the IAPT programme was born out of the best intentions to really genuinely increase access for people to evidence-based care. And I think originally in the programme, we knew that people would be coming through with long-term conditions. However, the focus very much on anxiety and depression, and it was more of a kind of silo-based approach through no kind of intention. And what we know is obviously the IAPT programme has grown from strength to strength, which is fantastic. It's not without its faults, as I'm sure everybody knows. There are challenges in any widespread national change. There are challenges in having lots of different providers delivering something and commissioned in slightly different ways. But we need to celebrate the success in terms of how many people have been seen since the start of the programme. For last year, for example, 1.69 million people seen in 2018, 2019. And of those, if we think about the huge number of people with long-term conditions, so 16.5 million people, roughly 17% of people have a mental health problem, but 30% of people with a long-term physical condition will have a comorbid mental health condition. And obviously the further we know, the further exacerbations with this, as we know, are things like the socioeconomic status that the person lives in, the challenges, the multi-morbidity of their physical conditions. So we really need to make sure that we're having an integrated approach to long-term conditions. And there's been some great work done to date in terms of pilot sites for the long-term conditions and integrated services. Graham, next slide, please. And as is one of the kind of key points I wanted to touch on is that it's really easy for things to fall into a silo mentality, and I think that's where we need to go next. And as IAPT, we have psychological therapists who are having specific training in long-term conditions and in the evidence-based NICE guidelines treatments. But obviously, it's not a panacea for everything. They're not experts in physical conditions in a lot of cases. Some will have backgrounds in physical health or occupational therapy, but a lot of people won't. And that's where the joined up working and approach really, really needs to break down those organisational barriers and meet that 5-year forward view. So we want to make sure that we really are integrated and that people don't feel either the stigma of a mental health problem to come forward for help when they have a long-term condition, and equally that some preventative work can be put into place to help people who are more at risk because of the long-term condition that they're facing. And I think certainly kind of leading on from what Charlotte was saying, which was really important in terms of integration, obviously we've now got the NICE guidelines underway for long COVID, and we need an integrated approach across that around things like breathlessness and some of the other kind of major symptoms that we'll be seeing. So I think there's been some good work done to date, but there's plenty more to do to break down those silo mentalities. And I think if we can absolutely ensure that we have really integrated some support, and we're working with companies such as Connect and other companies who have musculoskeletal services, if we're using incorporated training where we're hearing not just from psychological therapy experts in terms of what we should do to support people with long-term conditions, we really need to empower our workforce to make sure they understand the physical aspects of that as well, and that actually we're working in a collaborative care model. And I think for me, the missing link is actually developing that next stage within our primary care networks and making sure that we're working together to develop not just the kind of separate long-term conditions training for IAPT, but getting some much more integrated training as well around long-term conditions, around what may come through, around the fact that, you know, IAPT has a set of long-term condition difficulties that the clinicians are trained to work with. But as Charlotte has pointed out, people don't just come with those. People don't just come with anxiety and depression. We have lots of other conditions coming through, like endometriosis, like difficulties with other medically unexplained conditions, like with IBS. And we need to break those barriers down in every which way we can and actually reach out to people and say, you know, this service can support you in this way. It can help you with the transition of the long-term condition, but also it can help you in terms of your mood if you need that. And also we can signpost to other agencies for that support as well. And we see a much more kind of linked up, unified service approach in the future, hopefully. Next slide, Graham. Thank you. So we have the full implementation guidance for IAPT for the long-term conditions and medically unexplained symptoms. And I think what links really nicely to kind of the work that Charlotte's doing in terms of the qualitative voice, there are key statements within that the expert reference group put in terms of, you know, what patients really want from us. And I think it's now our duty to make sure that actually we're working with commissioners and engaging with stakeholders to make sure that we can deliver on these things. People want somebody that they can go to with questions at any time. They want to know how to access help for their difficulties and knowledge and expertise. What they don't want is to come to somebody for their anxiety, depression, mood, to manage the transition into a kind of acceptance of their condition, to then be saying, oh, actually, I don't know anything about pain. Actually, I'm not sure about musculoskeletal. Actually, what we need to be saying is, I work really closely with this person, and we've got a great relationship with our partner service or with our informal partner service, and this is our understanding of this. But actually, from your experience, you tell me, you're the expert in this condition because you have it. From your experience, talk me through it from your perspective. How can we best help you with this? And so I think jointly managed care, a collaborative care approach, was always the fundamental basis of depression work in the IAPT programme. So it absolutely should be able to work with this as well. Next slide, Graham, please. Thank you. So that's it from me, a very whistle-stop tour.
Thank you, Marie. So excellent talk. Can I just pick up? You've talked a lot about the long-term conditions, and just out of interest, so people are aware, at Connect Health, we are very much committed. I think you referenced it in your talk, from a physical health point of view, and in particular, we've been providing chronic pain services for a number of years, and being aware that more and more we're seeing people with mental health problems, and so we're coming in the direction of IAPT from physical health and want to complete that integration. And I think you and I and our organisations have talked about this and are sort of meeting in the middle. Where do you think the biggest resistance is going to be to long-term conditions? Because it's clearly been defined for IAPT providers, and there's the training. Is the problem, or not the problem, is it the physical health providers going to provide most resistance to this because they're very busy doing what they do and doing the biomedical side, or is it coming from the mental health services themselves?
I think it's an unintentional barrier or blockage that probably nobody recognises, because everybody's so busy, as you say, just dealing with the front of house and the back of house within their own organisations. In terms of resistance, I think you need to kind of break down the barriers that you either go to somebody for your mental health or you go to somebody for your physical health, and we actually have kind of this joint service or this joint umbrella that's commissioned if we can. Certainly from the kind of the clinicians I speak to, they really want to attend the long-term conditions training that's being commissioned every year. In fact, getting places for the increased expansion is kind of, we could fill those twice over, I'm absolutely sure. And, you know, I've done quite a lot of integrated work with digestive disorders units. I've just finished co-authoring an IBS app with Melissa Hunt from Penn University around kind of psychological support for irritable bowel syndrome that follows NICE guidelines. And actually we found no resistance on either side. Sometimes there can be some challenges on the patient side because they either see their problem as integrated and get frustrated by the number of hoops they need to jump through before they get to either of us, rather than just having that unified sharing of information and approach. But in the main, I think it is just the busyness, and that's probably what we need to do, is put a system in place.
Okay, I'm sure there'll be more questions or discussion on that at the end. So for now, thank you very much, Marie. And it provides a good segue into our next speaker, who's Dr. Ollie Hart. Ollie's a GP, has worked extensively, as I was referring to, with connecting chronic pain services, and is into a number of areas of practice, particularly around person-centred care. So I'm going to hand over to Ollie now, who's going to talk around and integration of mental health into primary care, which is clearly really important with PCNs. And I think he's going to tell us what the future holds, which will be interesting. So over to you, Ollie. Do we have Ollie ready and willing? Looks like we might be having some technical difficulties with Ollie. Okay, so what I might do then is I'm just going to perhaps see if our next speaker is ready. Oh, here we go. I think we're going to get Ollie. Oh yes, we're going to go to Claire. That was a good plan. Right, Claire, I hope you're ready, and we'll come back to Ollie straight afterwards. So I'd like to introduce Claire. Claire's a mental health nurse by background, worked extensively in IAPT services in various parts of the country and has particular interest in employment. She works for Connect Health as an occupational health manager and provides a great link between mental health and employment. And she's going to give us an outline of some of the issues that exist for people with mental health problems. So over to you, Claire.
Thank you, Graham. So as Graham's just said, my background is mental health nursing. I've also worked in public health and obviously health inequalities, mental health, it's all interlinked, and that's kind of where my interest lies. This is a huge subject, as you'll all know, and I've only got a few minutes, so it was a bit of a challenge to try and pick out where to focus these next few slides. But I think I'm going to err on the side of practicality, given what I think the audience, you know, looking at who we have in the audience, and so I hope that this is of interest to people and perhaps stimulate some thought and discussion. So if we can move on to the next slide, please. So I'm not going to go into too much depth here. We don't have time, and I don't think a lot of this will be news to anyone here. We know that unemployment and mental health are linked, and one shocking statistic is that just 43% of people with mental health problems are actually in employment, and that's just simply not good enough. Particularly when we're looking at the wide-ranging implications of unemployment, not only for those with existing mental health problems, but those with long-term conditions, and the wider community. So given, I mean, we've already touched on the pandemic briefly with Charlotte's presentation, but I think it's recognised and obvious really that mental health is expected to be a continuing growing concern post-COVID, as is unemployment. We've seen the impact on the economy. So I think now's a good time to start to refresh our memories and refresh our focus on employment in relation to mental health and particularly IAPT as well. So all of this is not news. Like I've said, there's lots of reviews, lots of evidence, lots of paper out there to support this evidence, starting, you know, decades ago. But not much has really changed, particularly in the last 10 years. There hasn't been the kind of impact that we would have liked to have seen on health inequalities. So hopefully one of the positives to come out of the pandemic is that we refresh our focus. And like I said there, employment is one of the most strongly evidenced determinants of mental health, so it definitely is worth our time. Can you move on to the next slide, please? So if we start at the right-hand side of the screen there, the health and work cycle is a really clear visual representation of how health and work coexist and are mutually dependent. And that's what we're all aiming for, really, a society where workers are productive, business is prosperous, individuals have their social and financial needs met and are in good health, and so the cycle perpetuates. And we've already seen a shift in thinking over the last couple of decades, like I've said. And for myself, working in occupational health at the moment, we see businesses spending a lot of money to provide good healthcare for their employees because they recognise the benefits to a healthy workforce. It helps people feel valued and cared for, and that all contributes to good business. So how are we achieving this utopia, if you like? Well, I think we need to be looking at reducing as far as possible unemployment and reducing sickness absence as far as possible. And IAPT services are a really good example demonstrating how this concept of work and health can be embedded into a healthcare model. It's not perfect, and it's going to evolve and change, and it may not be 100% understood in this way by everyone, but we can see the theme of employability throughout IAPT, through the operational manual, the commissioning guidelines, the KPIs. It all links back to employment in some way or another. So just to touch on a couple of the ways that IAPT is contributing, the areas such as expanding access, targeted provision, self-referral, digitisation, these are all ways of providing a work-friendly service, and it's sometimes overlooked. It's oftentimes overlooked actually in healthcare, where we want to provide an accessible service that's work-friendly. It's accessible for people who are in work. They're maybe in an unstable work, and by being able to offer flexibility in appointment times, as a simple example, that can make the difference between someone keeping their job or not. So that's a really strong way that IAPT is contributing. The other really important contribution is the integrated employment advisors and the focus of them in the IAPT service model. And we're already seeing good examples of the positive impact that they're providing. And I'll speak about that a bit more. So if we can move to the next slide, please. I'm not going to go into detail in each of these, and I did want to try and keep it practical and not just talk at people for too long. But these are just some examples of how healthcare providers and commissioners can contribute to the concept of good work and good health. And there's probably three most important areas in practical terms. Looking after your own workforce. Obviously, as I'm working in occupational health just now, that's forefront of my mind. So if you can be an exemplar employer and commissioner, knowing your providers, knowing what kind of health and wellbeing policies they have in place to support people with mental health issues or prevent mental health issues in the workplace, that can really help to shape the culture of an organisation. And I think if employees, particularly within healthcare organisations, if they're actively supported with their mental health, it kind of sets the standard for ensuring that focus filters down into the care that they provide. It kind of becomes part of your whole organisation and the service that you offer. And another key area is sort of the partnering and championing of other organisation. And that's also, oh, I'm getting feedback. Is my sound okay? I'm sorry. And another key area.
Yeah, Claire, that's fine. You keep going. We can hear you really well.
I can hear myself on delay. Sorry. Sorry. Yeah, partnering and championing other organisations. So I think we're very good at within healthcare at teaching others, telling other people what we do, promoting our services, and we tend to focus a lot of time and resource on awareness raising and campaigning about our services, and that's really valuable. It's really important and it has its place. However, we do seem to struggle a little bit when it comes to integration and listening, and I know that's a sweeping statement, but I think the best successes can be seen where we're being really effective at looking at how we cooperate and draw on the expertise of other organisations. And I think this is where it links with the employment advisors within IAPT. So we don't need to be the only experts in the field. We need to link with others. And I know that there are many voluntary sector organisations, community groups and others out there that have a similar type of role. And it can be confusing for patients knowing where to go, and everyone's working in silos. Mary mentioned that as well. So I think it's really important if as an IAPT service you have a strategy, a really clear strategy of how you're going to utilise those employment advisors in a way that truly integrates with the others providing that expertise in the community. So it's all joined up. We're not working in silos, and we're making it really easy for those organisations as well as our patients to work with us. And co-location is a crucial element of that, and the success of those roles. And one of the easiest ways of embedding employability is by co-locating, and it's the same in a lot of areas. It helps with communication, cooperation, mutual understanding. So yeah, there is a lot of positive work in that area, but I think if we had a more consistent approach and we were better able at sharing good practice, then maybe we could see some really robust success and research in that area to develop and take that forward. So I think Mary and also Charlotte touched on this, using influence as a system leader to influence and make it easier to cut through red tape, to reduce the bureaucracy, to enable that integration and co-location perhaps, and use your platform as a commissioner or a provider to encourage that cutting across professional boundaries and try and reduce that silo working. And this all links with innovation, transformation, improving access. So if we can move to the last slide. Sorry, I'm running over time.
Yeah, if you just finish off briefly.
I'll finish up here. Great. So it was just a brief slide on, as an individual healthcare professional, what could be done. And the three areas I would say to highlight is looking after yourself, makes you better able to look after others. Signpost, know what's available in the community to signpost and help your patients with employability issues, and access the Work and Health programme, which is a free training available for healthcare professionals.
Thank you.
Apologies.
No, thank you very much, Claire. What we're going to do, we're still having one or two technical difficulties with Ollie, so we'll bring your questions in at the end. Can I encourage everyone to put some questions on for our speakers, and we're going to move on to our last speaker and see if we can get Ollie on afterwards. So our last speaker is Minnie Mangit. I'm delighted Minnie's joined us. She's the head of patient engagement at Connect Health. She's got a number of roles as well, including an elected district councillor, and a long history of working with hard to reach groups in specifically BAME. So she's going to talk to us a little bit about developing approaches and tailoring services to the BMA community. So over to you, Minnie, and welcome.
Thank you, Graham. Good afternoon, everyone. Just want to say thanks to the previous speakers for their valuable contributions. Can I go to the first slide, please? Thank you. So, as we know, in terms of inequalities and equalities, addressing health inequalities has been a priority for mental health for a number of years, with it's been highlighted in the 5-year forward view and the mental health NHS long-term plan. With the situation with COVID-19 and the pandemic, it's become more important than ever. And as we know with the virus, there is economic and social impacts that are disproportionately affecting different groups, specific groups, and that will include the Black, Asian and minority, the BAME communities. So tackling inequalities, especially racism, it's vital, emotive and it's challenging. And from my view, it sort of requires leaders, organisations like ourselves and individuals to understand their own biases, beliefs and their behaviours. And it also requires every component of the systems that we operate in to acknowledge the stark reality of inequality. And we can only really tackle inequalities by understanding people's real life lived experiences of them and then act on that to make changes. Can I have the next slide, please?
Hello, it's Ollie here. Sorry I can't get your call. Please leave.
Thank you. So I just wanted to touch on things that influence ethnically diverse communities' mental health. So racism and discrimination. So people from BAME communities can experience racism in their personal lives, and it can range from anything like casual slights to explicit hurtful comments, verbal or physical abuse, aggression, and then the social and economic inequalities. These communities can often be faced with disadvantages in society. There's more likelihood of experiencing poverty, poorer educational outcomes, higher unemployment, and the BAME community may face challenges accessing or receiving appropriate professional services. And of course, then we've got the mental health stigma, and that's the institutional and the community perspective. Different communities understand and talk about mental health in different ways, and in some communities mental health is rarely spoken about and can be seen in a negative light, and I would say that this can discourage people from talking about their mental health, and definitely a barrier to engaging with health services. And then just very quickly to touch on the criminal justice system, there is a growing concern over unmet mental health needs amongst the BAME individuals that are maybe in the criminal justice system. And then intersections. So many groups face inequalities in physical and mental health, and this can be due to other factors such as disability, sexuality, gender, age. And I would say to understand BAME communities' experience of mental health problems and of the services provided, it's really necessary to consider all other aspects in addition to race and ethnicity. And just very quickly to touch on some recent data from an IAPT programme, it sort of says that BAME communities are less likely than people from white British background to use IAPT services, to complete treatment, to reliably improve and to achieve full recovery. And I just wanted to touch on the fact that, you know, under the Equalities Act 2010, all of our services, you know, we have a legal duty for mental health services to provide equality of access and equality of outcomes for all. Could I have the next slide, please? Thank you. Thank you. So just wanted to touch on a few things around improving the BAME community's access to IAPT services and also the experience of IAPT services, because, you know, sometimes we can, you know, we may get the communities accessing, but then the experience might not be as good. So just wanted to touch on a few things around this. So in terms of person-centred care for people as people, I think that's really important to consider personalisation and a consideration of cultural background. And it's really important that the variances are driven by people and not the structures and the systems. And if we were to just put, you know, the treatments and the measures to one side for a moment, it's really about getting to know our local communities, and that's where it really starts. And if we look at IAPT services and communities coming together, you know, that's really, really important. So things like faith groups, places of worship, community centres, the third sector, voluntary sector, community interest organisations, and, you know, looking at practical improvements in language. So, for example, interpreting, translating, and even literacy support is really important, and meeting, you know, people's faith-related and religious needs, perhaps offering gender-specific services and workforce, and also increasing the ethnic diversity of our workforce. And I think, you know, it's really important in terms of actioning to address and reduce experiences of racism and discrimination. And then we're looking at sort of listening to our communities and building trust with community groups. So understanding, empathizing is really important. You know, in terms of empathy, empathy drives connection. It's almost like feeling with people rather than about them. Recognizing behaviours and triggers relevant to particular communities which are often ignored. And I think it's really key that we keep the community at the heart of this work, and we wrapped IAPT services around the community and not to make the community fit to traditional models. So we know that one size doesn't fit all. Community organisations are often sensitive spaces where the BAME communities feel are safe spaces. So it makes sense to really work with people in scenarios where they already feel safe. Treatment is more likely to work where people feel safe and listened to. And my next bullet point says bridge work, and what I mean by that is sort of identifying gaps within the community. So supporting empowerment for communities to come to their own solutions almost. So we might think to ask communities, you know, what is it that they think that they want, and you know, what do they need? And the chances are we might get a response that actually, you know, we've never been asked that question before. And it's about having rich conversations with those community groups to kind of support them to come to the solution, their own solutions. I mean, often they do know what they need, they've just never been asked. And also hyper-local initiatives driven at grassroots level, micro-local level, and remembering that BAME is a really broad term and that there is much diversity within the different communities that we kind of term as BAME. Community education, really trying to encourage community champions to share their lived experiences from within the communities, and perhaps their stories of their own experiences of what the benefits of accessing IAPT might be, and delivering education and mental health services and messaging in places where there's high community traffic to keep people's engagement. Co-producing is really key, and sort of innovation around how we deliver IAPT, and it's important that we deliver IAPT in the community, with the community, for the community. Community-based projects to tackle stigma, you know, is a suggestion, and I'm sure, and I know there's lots of work already going on in these areas, and really having equal conversations for quality partnerships, possibly anchoring onto initiatives that are already happening. Many of our community colleagues across the country are already doing this work, and there may be scope for IAPT services to join their frameworks. It's really basically about whatever engages the interests of the community, and IAPT being a part of that, and supporting, sort of investing in the community and supporting sustainability. And if we see gaps, supporting to actually establish groups, if we see that they could be part of the pathway. And this is really key, is that, you know, co-production can't be a one-off isolated event. It has to be an ongoing journey, with an aim of establishing lasting relationships and connections. And it's not just as easy as taking our workshops to the community. It's more about adapting and co-creating culturally sensitive initiatives. And then we've got the workforce being reflective of the community and training for staff in cultural humility to ensure that people who access services or want to access our services feel culturally safe. I mean, for example, when someone's accessing our service, and you know, they may not see people from their own culture, or they might not see people that they may not relate with. That can be an added layer to the mistrust that they may have, or feeling uncomfortable. And when you access a service, you're already feeling uncomfortable, or maybe at your worst, and then, you know, to feel even more uncomfortable again due to the lack of cultural acknowledgement, it adds to the mistrust of services. And workforce is not always reflective of the community, as we know, and increasing a BAME workforce is key, as is training. And
Minnie,
can I
just jump in? If you could just finish off in about a minute, just so we can get to the question and answers. Sorry to interrupt you.
No problem. So
Thank you.
Just my last few points, which is about language and the types of language we use. So we all have good or bad mental health. It's about sort of changing that so that it doesn't have a negative connotation to maybe well-being. For example, the shift from committed suicide to died by suicide, it kind of changes the negativity. And then putting people first and just using data as a guidance. You know, and if we put people first, then outcome measures and evidence base just comes by default. And the last slide is really around tools and resources that are already out there and things that are already being done that people might find useful. Thank you very much. I think you're on mute, Graham.
Can you hear me now, Minnie?
Yes, I can. Thank you.
More technical problems. I think a lot of people listening in will be challenged with the requirements for the mental health 5-year view around access, long-term conditions, etc. I just want to focus in on access and ask each speaker, how can we engage the community to access mental health services, because we're all faced with the action plan for that. So from a BAME point of view, what are the two key things that we should do that can actually get those people in front of our practitioners?
What I'd say to that is actually it's about getting our practitioners in front of those people. I think that's the first thing, not the other way around. So it's reaching out and building relationships with communities, because there's a huge stigma in BAME communities about accessing mental health services. And sometimes it's about how we frame it, how we frame our services, and the language that we use. But for me, it's definitely about making that access easier by going to the community, working with the community and delivering culturally adaptive services right from the point of where they access. So it might already be in a community group that where they go to, we need to almost anchor onto things to make sure that we are there and sort of spreading the word around about education about services. Does that answer the question?
Yeah, thank you. Can I ask the same question of Charlotte from a patient point of view? Obviously, there are a lot of I statements that you've run through. I mean, how can we get patients and practitioners together over the next 4 to 5 years?
I think we have to have conversations about what matters to people and then take our lead from that. And that will force the integration agenda, because what matters to people tends to straddle all the silos. And therefore, rather than thinking, oh, who do I have to integrate with? The question should be, what does the person or the community I'm here to support say matters to them? And if it then transpires that it straddles health and care, or it straddles mental and physical health, or it straddles housing and health, then that's the integration agenda, isn't it? So kind of it needs to follow the conversation with the patient in front of you or the community you've been tasked with supporting. Does that make sense?
Yeah, it does, Charlotte. Can I just ask you a supplementary question? We did a pain seminar, and Connect developed a public education health literacy campaign called Flipping Pain, which has been incredibly successful, very much run by patients for patients. Is that an area that we need to concentrate on in mental health? So rather than trying to go through individual consultations and through GPs, etc., actually get out to the public and get a better understanding of mental health and what's available?
I think we both clearly, I wouldn't want to argue against good mental health services for people who have quite substantial needs or at points of really traumatic transitions or whatever. Clearly, we do need those, but we also need the other thing. We need a more grown-up conversation about health and well-being, and we need to take the whole self-management agenda much more seriously. Like, just thinking through the COVID situation again, as far as I know, not a single piece of information has been produced by NICE or the NHS or the government on how you look after someone who's got COVID at home, or how you look after yourself when you have COVID, which I think just tells you everything about where self-management is on the agenda. Nowhere. The vast majority of COVID care has taken place in people's bedrooms and living rooms. A very small proportion of COVID care has taken place in hospital. And we have not supported the people who do all that COVID care at home. There's no, as far as I can tell, there's no support with how do you support people who've got a high temperature, what does breathlessness look like, what are worrying signs and symptoms, nothing. And I think that's just, you know, an example of how we still have a complete blank when it comes to realizing that most healthcare happens in people's houses. And we need to just get much better. We need to tackle the quality improvement there. You know, how can we make that care better, more sustainable, more evidence-based on what actually helps and supports people? And that clearly applies to mental health.
Yeah, thank you. And that links in with one of the previous webinars around COVID recovery, and I think a concentration on what goes on in hospital, which is fine, that's much needed, but there's a huge need in the community as well. Thank you for that, Charlotte. I'll move on. I believe Ollie's available, and we're going to just ask for his.
Can you hear me? I'm just checking whether you can hear me.
Yeah, I can hear you. So Ollie,
great.
if I can give you a couple of minutes, perhaps just to cover a couple of your key messages, and also just that same question: how do we help people access numbers?
Yeah, sure. I'm really sorry about the difficulties. I think there's something about the NHS and these sort of platforms. I think that some of my key points really was just that it's just as Marie says, we've got to get away from silos. What we see with mental health and MSK problems in the community as a GP is that they're highly complex. A lot of the mental health stuff involves a significant degree of emotional complexity, trauma, as Charlotte's alluded to, wrapped in with all the social things like unemployment, drug and alcohol, low self-esteem. And everyone will recognise as well, then often there's a lot of overlay with MSK issues, and those tend to be multiple and complex as well. You know, chronic low back pain coexisting with fibromyalgia, plantar fasciitis, costochondritis, frozen shoulder, all those sort of things that just hang in there really. And I wanted to just sort of say we probably need to move away from a criteria-based service. I mean, I get that IAPT is often aimed at stuff where there's an evidence for something working, but in real life, people are very complex. And having a service where you're either in or out because your diagnosis fits or doesn't is not particularly useful. And we probably need to move towards, a service that is able to cope with messy, complex situations. And from a point of view of, how that integrates with service delivery, I had a picture of a zebra. And I don't know if I love that film, Madagascar. I don't know if you've ever heard anyone with Chris Rock being the zebra, and he sort of says, "Hey, I don't know, am I black with white spots or with stripes, black with white stripes, or white with black stripes?" And it makes me sort of think maybe we need to be looking at not just physios and counsellors, but physios are trained as counsellors and counsellors are trained as physios, so that it's indistinguishable, and we're moving away from the silos when we cross over MSK and mental health, because it's so interplayed. And of course, my last point is coaching skills for everybody. I think everyone needs to have coaching skills to make this work, but I'm bound to say that.
Ollie, can I just very briefly, 30 seconds, you're a clinical director for Primary Care Network. I know IAPT services, King's Fund, etc., charging IAPT services with linking with PCNs. When's that going to be possible? When are PCNs going to be ready?
I think they're maturing all the time, and you're right, it's tricky. COVID has set us back a bit because we've all been focused a lot on delivering vaccines and protecting services and so on, but the real benefit of primary care networks is it's going to encourage localized integrated solutions with new roles emerging. I think over the next 18 months to 2 years is a realistic timescale where you'll see PCNs really upping their game in terms of how they lead integration. Health and social, mental health and physical health coming together, but it will take a bit of time, but over that time scale it'll happen.
Okay, thank you. Apologies for not getting your full presentation, but thank you for joining us. Can I go to Marie now? The question was around access. You've got vast experience of IAPT services. How are we going to get anywhere near 25%?
I think one of the first things we need to do is probably change the way that we market services, in terms of doing much more partnership working, in terms of reaching out and doing much more integrated work with physical healthcare services. Now, a lot of that does go on at the moment, but I think we just need to get some brand awareness of IAPT out to those areas who quite often, you know, I've done a lot of work with some of our integrated physical healthcare services locally and nationally, who often say, wow, yeah, we'd heard of IAPT, but we didn't really think to draw the dots, or, oh, actually, we've never looked at it from that perspective. That'd be really helpful. So I think if we can make sure that it's on their radar when they go into people's homes, when they're seeing patients, when they're spotting signs, it will start to join those dots up. I think the other thing we need to do is much more collaborative training. So yes, we've got the integrated IAPT training, but that's for IAPT staff, and I think we're missing a trick there in terms of getting people together in the room for more training around, actually, this is what each other's services can offer each other at a local and national level. And I think that would be really, really beneficial as well, because I think that would help to bring people together in a way that hasn't been done before through the current kind of commissioning and structure models that we've got. Okay,
thank you very much. I'm going to move on to a question for Claire that's come in. So Claire, this is around COVID unemployment. So clearly things were challenging before COVID, and there's lots of different aspects of how COVID's going to impact on us in the next who knows how long, one of which is unemployment. I mean, how's that going to be in the mix in terms of IAPT services trying to help people back into work? People with COVID?
I think it's just going to strengthen the policy drivers that are already in play. To be honest, it's going to bring it to the top of the agenda. I expect. I think everyone's anticipating an upsurge in referrals to IAPT and other mental health services and possibly other physical health services. So I don't think anything new particularly is on the horizon. It's just going to strengthen the stuff that's out there already. And don't know, Mari might be in a better position to answer that in terms of what's coming, but that would be my thought. We already have a strong focus on employment and employability and improving that within the mental health arena. COVID's just going to increase that problem, so therefore we need to put more emphasis on it. So that would be my thought on that, Graham.
Thank you. So just a question for Ollie that's come in from Dr. Unsworth around funding to address needs. Where's the money going to come from? I know there's money promised, but what we're going to see with the new requirements in 2021 with post-COVID.
Yeah, thanks. I wonder if that's David Unwin from Southport. Yeah, money's always a thing, isn't it? I think what we always forget, though, is that there's already a huge amount of money in the health system. And sometimes it's just about reattributing it and repurposing how we do things. So, you know, this proactive approach to engage people around an integrated agenda, if anything, requires a mindset shift more than it requires finance. It always helps to have new roles, and there is lots of money coming to PCNs for these additional roles. I think my network's going to get about 20% increase in workforce. But what will really multiply that effect will be the mindset shift of the rest of the profession, I think.
Okay, thank you. Thank you very much. I'm just going to ask, we've got a couple of minutes left. One very short question to everyone. So moving into 2021, do you think we need to reset our targets because of COVID, or is it reasonable to push on to 25% and accessing long-term conditions across the board? So 10, 15 seconds each. If I could start with Charlotte. Where would you put the emphasis in 2021?
I'm not close enough to the data to know whether 25% is realistic or not. I think what I see makes me think existing service models won't hack it. We need to complement or redesign them with real community-based, volunteer-based, peer support-based, socially embedded models, because the wave of need around mental health is just enormous.
Okay, and Marie, could I ask you the same question? Targets, where should we be aiming?
Sorry, Graham, could you just repeat the question there? Sorry, my sound went with my dog barking.
Apologies. Yeah, the 25% meeting long-term conditions, BAME, and now we've got COVID. Where do you think we should be focusing in the next 12 months?
I don't think it's an either or. I think we need to focus across all. IAPT put out with the BABCP a fantastic IAPT positive practice guide to increasing access to BAME groups. That has an audit in that all services are being encouraged to undertake, both in terms of people accessing the services and staff profiles. With COVID, I think we need to wait for the long-term guidance to come out to know exactly what to deliver to make sure we're doing the right things for the right people at the right time. But I do think we need to be monitoring, as is happening at national level, in terms of access rates, because we had a dip at the start of COVID, and we're starting to see referrals increase across the board, but we're not yet seeing the high rise that's kind of predicted. So it's hard to know kind of where we'll be in 6 months or 12 years, and there's some capacity and demand modelling taking place within IAPT nationally for that, which is going to be really helpful. So I don't think we can separate those things out. I think we need to be having a unified approach across all of those things, which obviously means lots of work and lots of people and lots of resources needed, probably more than kind of went into the original plan this year for expansion.
Thank you, Marie. I'm aware we've run out of time now, so apologies for not getting around the other speakers with that question. I'd just like to thank all the speakers for their contribution today. For everyone who's been on the webinar, thank you for joining us. It's a challenging time. We've got a challenging 12 months ahead of us, but we're looking forward to meeting all those targets that have just been mentioned by Marie in unison. So just to finish up, to say that we have further webinars coming up. You might be particularly interested in the clinical psychology and pain, which obviously relates into mental health significantly, which is on the 24th of February. I'd encourage you to visit our website, connecthealth.co.uk, to see the full lineup and the list of speakers. And just thank you to everyone who organised the webinar today. Thank you for attending, and have a good afternoon.